So it is my pleasure to introduce Professor Ahmed Abdel Aaty. Actually, the two titles which were delivered to the speaker is mirror image, but Dr. Magdi changed it a little bit. So if I understood correctly, Professor Ahmed Abdel Aaty will mention the cardiac approach in a patient with a kidney disease from the cardiology point of view. And Professor Magdi will do the reverse. Please do, Professor Ahmed Abdel Aaty.
Thank you, Dr. Ahmed, for this kind invitation and kind introduction. I am happy to be with you today. It's a pleasure for me to be in the field of nephrology, and congratulations for this eminent, prestigious conference. My agenda will be about some points in the cardiology with the renal impact. I will be talking about the cardiac renal patient with heart failure with reduced ejection fraction, which is a common scenario in our daily practice, and about the acute coronary syndromes, whether STEMI or non-STEMI, and the situation in renal dysfunction. As a matter of fact, CKD and heart failure frequently coexist, and usually we say that the patient with renal impairment live with a renal impairment and die with a cardiac disease. So the link between both renal and kidney is a very important link morphologically and as regards the prognosis. CKD may worsen cardiovascular function, causing heart hypertension and vascular calcifications, and heart failure may worsen renal function through the effects of neurohormonal and inflammatory activation, increased venous pressure, hypoperfusion, oxidative stress, and a lot of mechanisms other than this. For heart failure with reduced ejection fraction, I mean ejection fraction less than 40%. Above 50% is normal, less than 40% reduced ejection fraction. From 40 to 50, we call it mid-range systolic dysfunction. CKD is a major independent determinant of increased mortality and morbidity in heart failure. However, there are settings in which changes in serum creatinine are not associated with worse outcome. In our daily practice, we see a lot of patients with our medications or our interventions got a mild decrease in renal function, and we got a panic as a cardiologist, and also the patient is his family. We are using drugs in the treatment of heart failure with reduced ejection fraction with CKD. What we will do? We use RAAS inhibitors, the angiotensin receptor neprilysin inhibitor, or recently the sodium glucose transporter inhibitors. All these drugs are now armamentarium in the treatment of heart failure. They are cornerstones. Without these drugs, our patient will die. But with using these medications, we face a transient decrease in renal function, which should not prompt their interruption. We have to continue because this slow or decrease or mild decrease in renal dysfunction is mechanismal, is not pathological, it's not deleterious to the kidney. An increased serum creatinine of 25 milliliter per minute per square meter can be considered as acceptable in our patients. When we use the ARNI, the Sacubitril, valsartan, Entresto, the paradigm heart failure study, compared with enalapril, led to a slower decline, compared to enalapril, slower decline in renal function despite a slight increase in the urinary albumin-creatinine ratio and improved cardiovascular outcome. So in spite of, by using these medications, there is a drop in renal function, but finally the cardiovascular outcome is marvelous. We are using beta blockers also, the vasodilating beta blockers. They reduce mortality in heart failure with reduced ejection fraction, with moderate and moderate to severe GFR or renal dysfunction. But we have limited experience in patients with severe renal dysfunction with beta blockers. The cornerstone in treatment of acute heart failure as well as chronic heart failure whenever the patient is congested is the diuretic. Small and transient rise in serum creatinine during treatment of acute heart failure are not associated with poor outcome when the patient is free of congestion. So randomized trials have shown that patients with heart failure and concomitant CKD are at higher risk of events, but the beneficial effects of medical treatment are similar, if not greater than in the patients with renal function. So the benefit of the medical treatment in patients with HFrEF with renal impairment is more than patients without renal impairment. And we say that whenever the risk is higher, the benefit of medical treatment is higher. IV diuretics are the cornerstone of acute heart failure. We usually use loop diuretics. If there is no response, we can add combination with loop and thiazide diuretics with the limitation of the thyroid risk in renal impairment. But our target should be the lowest dose that can achieve the best efficacy. Usually we rush in the emergency with a very big doses of loop diuretics, furosemide, 120 milligram, intravenous, one shot, and so on. By this maneuver, we have got so much problems with the patients, hyponatremia, marked renal dysfunction, but we usually advise our colleagues that please use a small dose and taper, increase the dose, wait for the response first, and then you can increase the dose. So our slogan in the treatment of diuretics, target should be the lowest dose that can achieve the best efficacy. As I said, furosemide is a drug of choice for us. A satisfactory diuretic response can be defined as a urine sodium content more than 50 to 70 milliequivalent per liter at 2 hours, and or by urine output more than 100 to 150 milliliter per hour during the first 6 hours. So we have to give a small dose and wait for the result, look for the urine output after 6 hours. This is the regimen I said about. You know very well the role of diminished renal function on cardiovascular mortality, the salt and water retention, the cardiac extentability, the remodeling, progressive increase in left ventricular dimensions, more stress on the myocardial wall, ischemia due to this stress, renal matter incompetence, and this circuit is a vicious circuit. So much there is salt and water retention, the heart failure with progressive dilatation of the left ventricle, and the progressive congestion. That's why the salt and water retention should be cut at this vicious circuit. When we fail by using these diuretics by this regimen, and the patient is oliguric, congested, hypotensive, we refer for ultrafiltration, of course. Ultrafiltration for us is mandatory in our patients, especially if there is cardiogenic shock, and a lot of difference between the diuretics and ultrafiltration. There is benefits of the ultrafiltration more than the use of diuretics. And the recent player in the field of heart failure management, the sodium glucose cotransporter 2 inhibitors, the gliflozin, lead to slower decline again in renal function. The same like happening with RAAS and the ARNI. A slower decline in renal function compared with placebo, both in heart failure with reduced ejection fraction and those with CKD. But luckily enough, this decrease in renal function compared to the placebo is markedly significant, less than the placebo, and is 4 times slower than the decrease in renal function with other drugs. So they lead to drop in renal function, but slow and not a severe drop. In our patients with refractory heart failure, we use CRT, cardiac resynchronization therapy, left ventricular assist device. Is there any problem with a patient with renal dysfunction? There is no problem. And the benefit is equal in patients with heart failure, with reduced ejection fraction, with or without CKD. The problem in ICD, implantation of cardioverter defibrillator. We implanted this apparatus to give electric shocks when the patient feels arrhythmia to save his life. But actually in patients with CKD, this ICD is not that successful like that of patients without CKD, because in patients with CKD, there are a lot of non-arrhythmic causes or non-ischemic causes for arrhythmia for this. So a lot of failure we see in ICDs in patients with CKD than with patients without CKD. Again, the problem in all the trials, they exclude patients with severe advanced renal dysfunction. All the trials like this. But fortunately, these new trials, the DABA, CKD, the Emperor Reduce, the Galactic Heart Failure, the Victoria, you see all these trials use a GFR less than 30. And this is a very good point, because now we can have a knowledge about patients with severe advanced renal dysfunction and how to treat these patients with our armamentarium with drugs. So these good trials or recent trials will give us an important knowledge how to deal with patients with severe renal dysfunction in this situation. Our daily problem in our patients with diuretics, with RAAS inhibitors, that we have electrolyte disorders, hyperkalaemia, hyponatremia. We suffer all these problems. Hypokalemia is very common in patients with heart failure due to the diuretics, the extensive use of diuretics, and it approaches 50% of our patients with heart failure and CKD. Hypokalemia is often due to thiazide diuretics, as well as it can cause lethal complications. So our fear in our patients with HFrEF, with CKD, the problem of hypokalemia, which is very common, we can treat with RAAS inhibitors, potassium-sparing diuretics, with the caution in the renal function situation. Hyperkalemia, again, which is mild or moderate or severe, as you see, the margin between mild, moderate, and severe in hyperkalemia is very narrow. In these phases or stages of hyperkalemia, we have a lot of problems and can cause severe mortality in these patients. So our problem of hyperkalemia, imagine the incidence of hyperkalemia in patients with heart failure is about 50%, but in chronic patients, it's about 40%. In patients with heart failure, with CKD, it is up to 73%. So our problem in patients with heart failure, with CKD, is hyperkalemia, which is very common. How to deal with this hyperkalemia? In this situation, we need to stop our armamentarium, the RAAS inhibitors, the ARNIs, the Sacubitril. All these are drugs we can stop, but renal dysfunction and hyperkalemia are the major causes of moderate RAAS inhibitors, particularly mineralocorticoid clinical practice. We have to stop these if there is severe hyperkalemia like this. Hyponatremia is also another important problem. About 30% of our patients, due to the extensive diuresis, they suffer from hyponatremia, which is an independent marker of poor prognosis. Of course, the judicious use of loop diuretics can improve the incidence of this hyponatremia. The last point in my lecture, our patients with acute coronary syndromes with CKD. We have two types of acute coronary syndromes, the non-ST elevation MI and the STE elevation MI. For the non-STEMI, usually we have a conservative approach in our patients, and we refer for invasive approach for patients with high risk. But the guidelines in the European Society in 2020 showed us that it is recommended to apply the same diagnostic and therapeutic strategies in patients with CKD with dose adjustment, and this is class 1 recommendation. There is consensus that we have to treat our patients with CKD in STEMI, non-STEMI, with the same like the non-CKD patient with just dose adjustments. This class 1 recommendation at consensus. It is recommended to assess kidney function by GFR, not by serum creatinine or blood urea. Again, this class 1 recommendation, and there is consensus for this. Then, if we refer to the invasive strategy, we'll do an intervention, we'll do a diagnostic coronary angiography, we'll use a lot of dye during diagnosis and during intervention, in deploying the stent and so on. We'll use a lot of urographene or contrast in this situation. The guidelines tell us use low or osmolar contrast media at lowest possible volume are recommended in invasive strategy. Again, class 1 recommendation, level of evidence A, very high level. Pre and post hydration with isotonic saline should be considered if expected contrast volume more than 100. It's class 2A, and there is consensus for this. Also, this hydration, it should be done, but could be tailored to the patient. If your patient is not so dehydrated or well hydrated, so you have to use this hydration according to the circumstances of your patients, class 2B. Then the final decision after your diagnostic coronary angiography will go for PCI with stents or go for CABG. CABG is preferable for patients with CKD. Usually in patients with CKD, we are confronted in coronary angiography with a lot of coronary lesions. Patients with diabetes and patients with CKD, whenever we do a coronary angiography, we do not expect a single vessel disease or a mild lesion. Usually, we have multiple lesions. Even in STEMI, we are tackling the culprit lesion causes for acute MI. During the process of diagnostic coronary angiography, we are sure that we'll see the vessel occluded responsible for the acute MI, and we'll have another vessel at a distance will occlude it also at the same time. So the possibility of a multi-vessel coronary lesions in patients with CKD is always there. And our decision, usually we prefer CABG for these patients to prevent the high mortality with the multiple stents and the multiple in-stent stenosis and in-stent thrombosis in this kind of patients with hypercoagulable state in this situation. So in patients with CKD and STEMI, we have an emergency. The patient with STEMI, we have 90 minutes from door to balloon in order to sacrifice the myocardium. So we don't have any time for hydration of the patient. Sometimes we don't have time to assess the renal function for these patients because the patient is coming with ST elevation MI, the ECG is very bad, starting bradyarrhythmia, tachyarrhythmia. So we are in hurry to do intervention in these patients. We don't have any time or luxury for hydration of the patient or even to assess the renal function. We are saving the life of the patient. That's a very big problem in patients with STEMI. And then after we do this, we start to evaluate the renal function. We start to evaluate how much contrast we give, and then we can wait and expect acute kidney injury after that. But by any means, we have to do assessment, even rapid assessment of renal function in these patients. Of course, we have no time for hydration, but if you have the patient with renal dysfunction, with acute STEMI, we have something to do. Usually we do coronary angiography from the femoral approach. In patients with CKD, we prefer the radial approach because if there is a trauma for the vessel or any bleeding, you can see it. But in the femoral approach, you can find internal bleeding encroaching on the kidney at the same time. So our approach for the intervention, usually we refer to the radial approach in CKD patients than the femoral approach. If the patient missed the window of intervention, the 90 minutes to do a PCI or primary percutaneous intervention, we have the possibility of using thrombolytic therapy. There is no contraindication in thrombolytic therapy with patients of acute STEMI and CKD. So as I said, we give a lot of dye. We did not assess the renal function of that patient. We are waiting for kidney injury or acute kidney injury because the hallmarks of acute kidney injury in this situation, 2 points, the baseline CKD stage and the presentation of cardiogenic shock. So if there is renal dysfunction, whatever the degree, and there is cardiogenic shock during presentation, we have to wait or expect the presence of acute kidney injury. All these parameters or risk factors usually are there in this situation: anemia, diabetes, need for blood transfusion, and so on. So my conclusion, my dear colleagues, CKD is prevalent in coronary artery disease patients and is a prognostic factor for mortality and vice versa. Identification of renal impairment and the efforts to maintain a stable kidney function or CKD stage should be of major importance in all CED or coronary artery disease entities. Management of these patients should be done in 3 aspects. Firstly, CKD contributes as a risk factor in both clinical and bleeding risk scores, while giving anticoagulants, antiplatelets, combination, and so on. Secondly, healthcare providers must keep in mind that dosing of many cardiovascular drugs should be adjusted according to the renal function. Finally, preventive hydration is a cornerstone of acute kidney injury prevention when contrast media are used for angiographic intervention. So my take-home message, my dear colleagues, when RAAS inhibitors, ARNI, or sodium glucose transporters inhibitors are used or started, the initial decrease in the glomerular filtration rate, glomerular filtration pressure may decrease GFR and decrease serum creatinine. However, these changes are generally transient and occur despite improvement in patient outcomes and slower worsening of renal function in the long term. So we have to assure the patient, we have to explain the patient that this maneuver will cause a drop in renal function. It's a slow drop, it's not dangerous, and we have to proceed to save his life. We have to explain to the family of the patients, because every day our scenario, the problem with the patients, there was a little elevation in serum creatinine, the patient is afraid about his kidney, and the family at the same time, and usually forgot that we are saving his life. Thank you very much.
Thank you very much, Professor Abdel Aaty. I think we do have 1 minute for a couple of questions. Okay. Of course, Professor Aaty will, his presence is important till the end of the session. Okay. Yeah, sure.